Good day everyone, Norlin Solomon here. Today we'll be exploring Cluster C personality disorders, a category of mental health conditions that are characterized by anxiety and fear-based behaviors. These disorders are often misunderstood and can significantly impact a person's day-to-day functioning and relationships. Cluster C disorders are part of the broader category of personality disorders, which are long-standing patterns of behavior, cognition, and inner experience that deviate from the expectation of the culture around them. These patterns are pervasive, inflexible, and can cause distress or impairment in social, occupational, or other important areas of functioning. The three main personality disorders in Cluster C are avoidant personality disorder, dependent personality disorder, and obsessive-compulsive personality disorder. While these disorders share certain traits such as an underlying sense of anxiety and fear, each has its unique features. Throughout this presentation, we'll take a closer look at each of these disorders, what they are, how they manifest, and how they differ from one another. And we'll also touch on potential causes, diagnosis, and treatment options. So let's begin by diving into the first disorder in Cluster C, avoidant personality disorder. Avoidant personality disorder. As the name suggests, people with avoidant personality disorder are extremely sensitive to the opinions of others, and although they desire social relationships, their anxiety leads them to avoid such association. Their extremely low self-esteem, coupled with a fear of rejection, causes them to be limited in their friendship and dependent on those they feel comfortable with. Consider the case of Jane here. Jane was raised by an alcoholic mother who had borderline personality disorder and who abused her verbally and physically. As a child, she made sense of her mother's abusive treatment by believing that she must be an intrinsically unworthy person to be treated so badly. As an adult in her late 20s, Jane still expected to be rejected when others found out that she was inherently unworthy and bad. Jane was highly self-critical and predicted that she would not be accepted. She thought that people would not like her, that they would see she was a loser, and that she would not have anything to say. She became upset if she perceived that something in even the most fleeting encounter was reacting negatively or neutrally. If a newspaper vendor failed to smile at her, or a sales clerk was slightly curt, Jane automatically thought it must be because she was somehow unworthy or unlikable. She then felt quite sad even when she was receiving positive feedback from a friend. She discounted it. As a result, Jane had few friends and certainly no close ones. Chedormilion, who initially proposed this diagnosis, notes that it is important to distinguish between individuals who are asocial because they are apathetic, affectively flat, and relatively uninterested in interpersonal relationships, and individuals who are asocial because they are interpersonally anxious and fearful of rejection. So it is the latter who fit the criteria of avoidant personality disorder. These individuals feel chronically rejected by others and are pessimistic about their future. When it comes to causes, some evidence has found that avoidant personality disorder is related to other sub-schizophrenia-related disorders, occurring more often in relatives of people who have schizophrenia. So, a number of theories have been proposed that integrate biological and psychosocial influences as the cause of avoidant personality disorder. For example, these individuals may be born with a difficult temperament or personality characteristics. As a result, their parents may reject them or at least not provide them with enough early and critical love. This rejection in turn may result in low self-esteem and social alienation, conditions that persist into adulthood. Limited support does exist for psychosocial influences in the cause of avoidant personality disorder. For example, a group of people with avoidant personality disorder and a group of controlled participants avoid their early treatment by their parents. Those with the disorder remember their parents as more rejecting, more guilt, engendering and less affectionate than the control group, suggesting parenting may contribute to the development of this disorder. Similarly, research has consistently found that these individuals are more likely to report childhood experiences of neglect, isolation, rejection, and conflict with others. Diagnostic criteria for avoidant personality disorder according to DSM-5-TR. So, a pervasive pattern of social inhibition, feeling of inadequacy, and hypersensitivity to negative evaluation beginning by early adulthood and present in a variety of contexts as indicated by 4 or more of the following. First, avoid occupational activities that involve significant interpersonal contact because of fears of criticisms, disapproval, or rejection. Second, is willing to get involved with people unless certain of being liked. Third, shows restraint within intimate relationship because of the fear of being shamed or ridiculed. 4, is preoccupied with being criticized or rejected in social situation. 5, is inhibited in new interpersonal situation because of feelings of inadequacy. 6, views self as socially inept, personally unappealing or inferior to others. And 7, is unusually reluctant to take personal risks or to engage in any new activities because they may prove embarrassing. Treatment for avoidant personality disorder. In contrast to the scarcity of research into most other personality disorders, there are a number of well-controlled studies on approaches to therapy for people with avoidant personality disorder. Behavioral intervention techniques for anxiety and social skills problems have had some success because the problems experienced by people with avoidant personality disorder resemble those of people with social phobia. Many of the named treatments are used for both groups. Therapeutic alliance, the collaborative connection between therapist and client, appears to be an important predictor for treatment success in this group. Now let's proceed to dependent personality disorder. We all know what it means to be dependent on another person. People with dependent personality disorder, however, rely on others to make ordinary decisions as well as important ones, which results in an unreasonable fear of abandonment. Consider the case of Karen. Karen here was a 45-year-old married woman who was referred for treatment by her physician for problems with panic attacks. During the evaluation, she appeared to be worried, sensitive, and naive. She was easily overcome with emotions and cried on and off throughout the session. She was self-critical at every opportunity throughout the evaluation. For example, when asked how she got along with other people, she reported that others think I'm dumb and inadequate. Although she could give no evidence as to what made her think that, she reported that she didn't like school because I was dumb and that she always felt that she was not good enough. Karen described staying in her first marriage for 10 years even though it was hell. Her husband had affairs with many other women and was verbally abusive. She tried to leave him many times but gave in to his repeated requests to return. She was finally able to divorce him, and shortly afterward, she met and married her current husband, whom she described as kind, sensitive, and supportive. Karen stated that she preferred to have others make important decisions and agreed with other people to avoid conflict. She worried about being left alone without anyone to take care of her and reported feeling lost without other people's reassurance. She also reported that her feelings were easily hurt, so she worked hard not to do anything that might lead to criticisms. Individuals with dependent personality disorder sometimes agree with other people when their own opinion differs so as not to be rejected. Their desire to obtain and maintain supportive and nurturant relationship may lead to their other behavioral characteristics, including submissiveness, timidity, and passivity. People with this disorder are similar to those with avoidant personality disorder in their feelings of inadequacy, sensitivity to criticism, and need for reassurance. However, people with avoidant personality disorder respond to this feeling by avoiding relationships, whereas those with dependent personality disorder respond by clinging to relationships. So, it is important to note that in certain culture, dependence and submission may be viewed as a desired interpersonal state. So, in terms of causes and treatment, we are all born dependent on other people for food, physical protection, and nurturance. Part of the socialization process in most culture involves helping us live independently, and it was thought that such disruption as the early death of a parent or neglect or rejection by caregivers could cause people to grow up. So it is clear, however, that genetic influences are important in the development of this disorder. What is not yet understood are the physiological factors underlying this genetic influence and how they interact with environment influences. So, when it comes to the treatment, literature for this disorder is mostly descriptive. Little research exists to show whether a particular treatment is effective. On the surface, because of their attentiveness and eagerness to give responsibility for their problems to the therapist, people with dependent personality disorder can appear to be ideal patients. That very submissive, however, negates one of the major goals of therapy, which is to make the person more independent and personally responsible. So, therapy therefore progresses gradually as the patients develop confidence in his ability to make decisions independently. So, there is a particular need for care that the patient does not become overly dependent on the therapist. So, this is the diagnostic criteria for dependent personality disorder, which is a pervasive and excessive need to be taken care of that leads to submissive and clinging behavior and fears of separation, beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. 1. Has difficulty making everyday decisions without an excessive amount of advice and reassurance from others. 2. Needs others to assume responsibility for most major areas of his or her life. 3. Has difficulty expressing disagreement with others because of fear of loss of support or approval. Note that these do not include realistic fears of retribution. 4. Has difficulty initiating project or doing things on his or her own because of lack of self-confidence and judgment or abilities rather than a lack of motivation or energy. 5. Goes to excessive lengths to obtain nurturance and support from others to the point of volunteering to do things that are unpleasant. 6. Feels uncomfortable or helpless when alone because of exaggerated fears of being unable to care of himself or herself. 7. Urgently seeks another relationship as a source of care and support when a close relationship ends. And lastly, 8 is unrealistically preoccupied with fears of being left to take care of himself or herself. And finally, we have the obsessive-compulsive personality disorder. People who have obsessive-compulsive personality disorders are characterized by a fixation on things being done the right way. Although many might envy their persistence and dedication, this preoccupation with details prevents them from completing much of anything. Consider the case of Daniel here. Each day at exactly 8 a.m., Daniel arrived at his office at the university where he was a graduate student in psychology. On his way, he always stopped at the 7-Eleven for coffee and New York Times. From 8 a.m. to 9:15 a.m., he drank his coffee and read the paper. At 9:15 a.m., he recognized the files that held the hundreds of papers related to his doctoral dissertation. Now, several years overdue, from 10 a.m. until noon, he read one of these papers highlighting relevant passages. Then he took the paper bag that held his lunch, always a peanut butter and jelly sandwich and an apple, and went to the cafeteria to purchase a soda and eat by himself. From 1 p.m. until 5 p.m., he held meetings, organized his desk, made lists of things to do, and entered his reference into a new database program on his computer. At home, Daniel had dinner with his wife and then worked on his dissertation until after 11 p.m. Although much of the time was spent trying out new features of his home computer, Daniel was no closer to completing his dissertation than he had been 4.5 years ago. His wife was threatening to leave him because he was equally rigid about everything at home, and she didn't want to remain in this limbo of graduate school forever. When Daniel eventually sought help from a therapist for his anxiety over his deteriorating marriage, he was diagnosed as having obsessive-compulsive personality disorder. Like many with this personality disorder, Daniel is work-oriented, spending little time going to movies or parties, or doing anything that is not related to his graduate studies. Because of their general rigidity, these people tend to have poor interpersonal relationships. This personality disorder seems to be only distant related to obsessive-compulsive disorder. People like Daniel tend not to have the obsessive thoughts and the compulsive behaviors seen in the like-named obsessive-compulsive disorder. Although people with anxiety disorder sometimes show characteristic of the personality disorder, they show the characteristic of other personality disorder as well. Example, avoidant, histrionic, or dependent. So, an intriguing theory suggests that the psychological profiles of many serial killers point to the roles of obsessive-compulsive personality disorder. So, Ferreira here notes that these individuals do not often fit the definition of someone with several mental illness, such as schizophrenia, but are masters of control in manipulating their victims. Their need to control all aspects of the crime fits the pattern of people with obsessive-compulsive personality disorder, and some combination of this disorder and unfortunate childhood experiences may lead to this disturbing behavior pattern. Obsessive-compulsive personality disorder may also play a role among some sex offenders, in particular pedophiles. Brain imaging research on pedophiles suggests that brain functioning in these individuals is similar to those with obsessive-compulsive personality disorder. The diagnostic criteria for obsessive-compulsive personality disorder according to DSM-5 here is a pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency, beginning by early adulthood and present in a variety of contexts as indicated by 4 or more of the following. First, is preoccupied with details, rules, list, order, organization, or schedule to the extent that the major point of the activity is lost. Second, shows perfectionism that interferes with task completion, like it's unable to complete a project because his or her own overly strict standards are not met. Next, is excessively devoted to work and productivity to the exclusion of leisure activities and friendship, not accounted for by obvious economic necessity. Fourth is overconscientiousness, scrupulous and inflexible about matters of morality, ethics, or values, not accounted for by cultural or religious identification. 5 is unable to discard worn-out or worthless objects even when they have no sentimental value. 6 is reluctant to delegate tasks or to work with others unless they submit to exactly his or her way of doing things. 7 adopts a miserly spending style toward both self and others. Money is viewed as something to be hoarded for future catastrophes. And lastly, shows rigidity and stubbornness. In terms of causes and treatment, there seems to be a moderate genetic contribution to obsessive-compulsive personality disorder. Some people may be predisposed to favor structure in their lives, but to reach the level it did in Daniel may require parental reinforcement of conformity and neatness. Therapy often attacks the fears that seems to underlie the need for orderliness. These individuals are often afraid that what they do will be inadequate, so they procrastinate and excessively ruminate about important issues and minor details alike. Therapists help the individual relax or use cognitive reprisal techniques to reframe compulsive thoughts. This form of cognitive behavioral therapy, following along the lines of treatment for obsessive-compulsive disorder, appears to be effective for people with this personality disorder. So just remember that in Cluster C personality disorder, people with avoidant personality disorders are extremely sensitive to the opinion of others and therefore avoid social relationships. Their extremely low self-esteem coupled with a fear of rejection causes them to reject the attention of others. And in terms of individuals with dependent personality disorder, they rely on others to the extent of letting them make everyday decisions as well as major ones. This results in an unreasonable fear of being abandoned. And lastly, people who have obsessive-compulsive personality disorder are characterized by a fixation on things being done the right way. This preoccupation with details prevent them from completing much of anything. So, treating people with personality disorder is often difficult because they usually do not see that their difficulties are a result of the way they relate to others. And personality disorders are important for the clinicians to consider because they may interfere with efforts to treat more specific problems such as anxiety, depression, or substance abuse. Unfortunately, the presence of one or more personality disorders is associated with a poor treatment outcome and a general negative prognosis. And that ends my report. Thank you so much for listening, and I hope guys you gain something from us. And have a great day. We're now signing off. Bye.